Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you so much, Bob. I'm going to be talking about treatment of fitter patients with newly diagnosed multiple myeloma who would be considered transplant eligible. So many of you have seen this slide before. This is the natural history of multiple myeloma. To make a long story short, the disease typically starts in a precursor phase of MGUS, or smoldering multiple myeloma, and then converts to active multiple myeloma as defined by what Dr. Orlowski, previously reviewed. At the time of active multiple myeloma, we treat with first-line therapy, and the goal here is to achieve a deep response, ameliorate symptoms of the disease, and provide them with the longest remission possible. But for the vast majority of patients, they will ultimately relapse. And with subsequent therapies, the duration of remission tends to be increasingly short, although the bispecific antibodies in CAR T-cell therapy have made that calculus a little bit more complicated. Nonetheless, I think that this emphasizes the need to put your best foot forward. So this is an insurance claims database study that looked at attrition across lines of therapy for both patients with newly diagnosed multiple myeloma who were felt not to be transplant candidates and those that were felt to be transplant candidates. And I think, insurance claims database records are somewhat limited, and I think that the level of attrition that's outlined here is probably a bit exaggerated. But I think that the important point to take here is that attrition does occur with each subsequent line of therapy, and that attrition is more pronounced for those patients who are less fit and not considered transplant eligible. So again, this idea of putting your best foot forward and providing the best therapy you can possibly provide as part of first-line therapy is critical. So this cartoon here just basically outlines, the fact that, for many patients, achievement of a deep response, and in particular, a measurable residual disease negative response, is oftentimes associated with a longer duration of remission. And certainly clinical trials that have shown improvements in MRD negativity in one arm of the study versus the other have typically translated into improvements in progression-free survival, and in many cases as well, overall survival as well. And when MRD has been tested as a prognostic marker, it is always very strongly associated with progression-free and overall survival. So as far as therapies for the fitter patients with newly diagnosed multiple myeloma, we have our proteasome inhibitors. And in this particular situation, bortezomib and carfilzomib are used most frequently, with ixazomib typically relegated to early relapse. We have our immunomodulatory agents, and thalidomide is not used so much in the US at this point, with lenalidomide being the IMiD for newly diagnosed patients that's preferentially used in the US, and pomalidomide used in early and later relapses. We have the monoclonal antibodies, including daratumumab, although we'll be showing you data in the newly diagnosed setting with the CD38 antibody isatuximab as well. And then we have our lovely corticosteroids, specifically dexamethasone. And we have 3 drug regimens that I will briefly review, and then we'll be spending a lot of time talking about the 4 drug regimens that have been emerging in the recent past. So there are a number of different considerations when you're choosing induction therapy for a patient with newly diagnosed myeloma. There's those patient-related factors, and that includes age or fitness. And obviously, since I'm talking about transplant-eligible patients, we're talking about a fitter patient population. When you're considering transplant, does that individual have caregiver support? Are there comorbidities in place that would preclude the safe application of high-dose melphalan chemotherapy? Can the patient adhere to frequent visits that occur after the transplant is complete. What is the patient's preference from a lifestyle perspective, and what is their performance status? And again, getting back to this frailty score, how fit or frail is the patient? There's the disease-related factors, which include, standard risk versus high-risk cytogenetics and genomic markers, the presence of extramedullary disease or plasma cell leukemia, the severity of clinical symptoms as assessed by CRAB, and then staging as well. And then there's the treatment-related factors, which includes access to standards of care therapy, costs and copay, route of administration, clinical trial availability, and toxicities that may overlap with some of the underlying comorbidities that the patient may harbor. So I'm going to start off with the determination study to just kind of set the foundation here. So determination was a study that was very similar to an IFM trial that was conducted at the same time, which looked at the triplet of lenalidomide, bortezomib, and dexamethasone with either an upfront transplant or a transplant that was deferred until relapse. So for those patients that received the upfront transplant arm, they got 3 cycles of induction RVD therapy, transplant, 2 cycles of post-transplant RVD consolidation, followed by lenalidomide maintenance until disease progression or the development of unacceptable side effects. The patients assigned to the deferred transplant arm got 8 cycles of lenalidomide, bortezomib, and dexamethasone, followed by lenalidomide maintenance until disease progression or the emergence of unacceptable side effects. The primary endpoint of the study was progression-free survival, with secondary endpoints including response, depth of response, overall survival, quality of life, and safety. So not surprisingly, application of upfront autologous stem cell transplantation to the RVD induction therapy led to a slightly more than 20-month improvement in median progression-free survival. That said, when you look at overall survival with long median follow-up, it is very similar, if not identical, between the 2 arms. And this has led to the really key piece of shared decision-making in this process, when making a decision as to whether or not a patient is going to pursue an upfront transplant or not. At least at our center at Levine Cancer Institute, for those patients that have high-risk disease biology, we strongly encourage upfront transplant for that group of patients because the improvement in progression-free survival is more pronounced. We also encourage that in patients who are perhaps older, perhaps in their mid-60s going into their 70s, because as you'll see in a moment, the progression-free survival is so long, if you don't transplant those patients up front, you may not have that opportunity subsequently. And as I always tell patients, transplant is always easier to tolerate when it's done as part of frontline therapy as opposed to the relapse scenario. So perhaps surprisingly, when you look at best response to treatment in this study, by traditional IMWG criteria, there was not a statistically significant difference in achievement of very good partial response or better in the transplant arm, nor was there a significant improvement in achievement of complete response or better. That said, that there was a higher rate of MRD negativity in the transplant arm, about 54% versus just about a third of those that did not get the upfront transplant. Now, on the right of the slide, you can see outcomes by MRD status, whether you got transplanted up front or not. And as you can see on the top 2 curves, if you achieved MRD negativity, regardless of how you got there, your progression-free survival was similar. If you were not MRD negative, the transplant arm clearly did better from a PFS perspective. The only caveat to this data is that this is a subset of the patients in this particular study, and this was not routinely assessed in all patients on this trial. Now, what about 4-drug therapies? Now, at the time of the IFM trial and determination, RVD was not considered a standard of care regimen globally. So the Cassiopeia trial was built to see if the addition of the CD38 antibody daratumumab would improve upon a globally approved induction strategy for transplant-eligible myeloma patients, specifically bortezomib, thalidomide, and dexamethasone. So the control arm got 4 cycles of VTD induction, followed by a transplant, 2 cycles of VTD post-transplant consolidation. The patients in the daratumumab arm received the same backbone therapy with the inclusion of daratumumab into both the induction and the post-transplant consolidation. Now, interestingly, in the study, there was a second randomization as well to either no maintenance therapy or daratumumab maintenance therapy administered once every 8 weeks for a total of 2 years. The primary endpoint of the first randomization was achievement of stringent complete response by the end of consolidation therapy, and the primary endpoint of the secondary randomization was progression-free survival. So as you can see here, patients that were assigned to the quadruplet versus the triplet did better from a progression-free survival perspective, with a 53% decrease in the risk of progression or death with the quadruplet over the triplet. You can see here on the right, those patients that achieved a complete response, the quadruplet still outperformed the triplet, and those that did not achieve a complete response, the quadruplet outperformed the triplet. Now, with regards to daratumumab maintenance therapy versus no maintenance therapy, not surprisingly, daratumumab won in this particular instance with a 47% reduction in the risk of progression or death with application of daratumumab every 8 weeks for a total of 2 years. So these are data that were presented at EHA recently, which looked at long-term outcomes of patients depending on whether they got daratumumab as part of their induction and post-transplant consolidation, as part of maintenance, both or none. And as you can see here, the green line, which is patients who got no daratumumab, either in induction, consolidation, or maintenance, they did the worst from a median progression-free survival at 32.7 months. Now, the other 3 groups that got daratumumab, either during induction and consolidation and maintenance, or one or the other, all of them did very well from a progression-free survival perspective. But as you can see, with long follow-up, the patients who got daratumumab as part of the initial induction and consolidation and maintenance therapy did the best from a progression-free survival perspective. And when you compare the PFS for the patients that got daratumumab as part of induction and consolidation and maintenance to those that got daratumumab as part of induction and consolidation and not in maintenance, there was a statistically significant difference with regards to PFS. So now we come to a polling question. So in the Cassiopeia trial, the addition of which one of the following agents to VTD was associated with improved progression-free survival? A, carfilzomib, B, daratumumab, C, isatuximab, or D, elotuzumab? And the overwhelming majority of folks have chosen daratumumab as the answer, which is absolutely correct. So a very well-versed audience. So I'm now going to go on to the Griffin study. Now, as I mentioned before, at the time of determination in Cassiopeia, and this applies to the Griffin study as well, VRD was not a pathway to registration in the newly diagnosed situation. The SWOG S0777 trial completely changed that, but these studies were designed prior to those data reading out. So what we wanted to do with the Griffin trial was basically complement what was being done with Cassiopeia globally and allow the VRD backbone, not VTD, but VRD, to potentially be used in combination with daratumumab in the US. So Griffin was a randomized phase 2 study that looked at VRD with or without daratumumab for newly diagnosed patients who were transplant eligible. The control arm got 4 cycles of VRD prior to transplant. 2 cycles of VRD post-transplant, and then went on to lenalidomide maintenance until disease progression or the emergence of unacceptable side effects. The control arm got the very same. However, they got daratumumab as part of induction, post-consolidation therapy after transplant, and they got daratumumab for the first 2 years of maintenance therapy. The experimental arm was allowed to continue single-agent lenalidomide beyond the 2-year time point. And the primary endpoint of this study was achievement of stringent complete response by the end of consolidation, with other endpoints including progression-free and overall survival, as well as safety and patient-reported outcomes. So when we look at depth of response, post-consolidation, you can see here that achievement of stringent complete response was achieved in 42.4% of those that got the quadruplet versus 32% for those that got the triplet, and this was statistically significant. However, with longer follow-up, the rates of stringent complete response improved and increased to nearly 63% for those that got the quadruplet versus a little over 45% for those that got the triplet. And not surprisingly, MRD data very much mirrored what we saw with regards to complete response. With longer follow-up, we began to see a progression-free survival advantage emerge with the quadruplet. So specifically, when you look at 4-year progression-free survival, that was an unprecedented 87.2% in the quadruplet arm versus 70% for the triplet. The hazard ratio for progression-free survival was 0.45, in other words, a 55% reduction in the risk of progression or death with the quadruplet over the triplet. And this has led to adoption of this particular quadruplet in the United States in many different practices. Now, that was a randomized phase 2 study, and again, it was designed to improve access to that quadruplet in the United States. But, again, during that period of time, SWOG S0777 emerged, and VRD became a pathway to registration. So the Perseus study was a similarly designed trial, which looked at the addition of daratumumab to the VRD backbone in a phase 3 context. One difference in the experimental arm here relative to Griffin is that for those that were on maintenance for 2 years, if they were MRD negative, they could drop the daratumumab and just continue lenalidomide, whereas those that were MRD positive would continue on the daratumumab and lenalidomide maintenance until disease progression. And the important thing here is that the primary endpoint of the study was progression-free survival. So with regards to achievement of complete response, I'm going to focus on best response here in the overall columns. And as you can see here, nearly 90% of patients achieved a complete response who received the quadruplet, relative to 70% of patients who got the triplet. When we look at measurable residual disease, you can see that the quadruplet outperformed the triplet, whether you look at the end of consolidation, 12 months into maintenance, 24 months into maintenance, or 36 months into maintenance. And when you get to 36 months into maintenance therapy, when you're looking at MRD negativity at 10 to the minus 6, you've achieved that in 64% of the patients on the quadruplet versus 31% of patients who received the triplet. With regards to progression-free survival, as assessed by cytogenetic risk, the quadruplet outperformed the triplet in patients with standard risk disease. And again, similar to the Griffin study, I want to show that 4-year progression-free survival, which here is over 90% for the standard risk patient population. So again, unprecedented progression-free survival for this group of patients. And, there's always this debate about whether CD38 antibodies are valuable in high-risk cytogenetic disease, and this is a study that shows that, yes, they are. So in the high-risk patient population, the quadruplet outperformed the triplet with regards to progression-free survival, but not surprisingly, those that had high-risk disease features didn't fare as well as their standard risk counterparts. On the right-hand side of the slide, you see the forest plot looking at a variety of different high-risk scenarios cytogenetically, and you can see that there's this trend in improvement in progression-free survival for all of these for those that have received the quadruplet. Now, the CD38 antibody isatuximab has also been evaluated in a quadruplet setting for transplant-eligible patients with newly diagnosed multiple myeloma. So GMMG HD7 study is a very important phase 3 study, which is looking at whether the addition of isatuximab to the VRD backbone as part of induction improves MRD negative rates prior to transplant. But importantly, it has a second randomization after recovery from transplant, which is assignment to maintenance therapy with either lenalidomide and dexamethasone or isatuximab, lenalidomide, and dexamethasone. And in this particular study, as you can see on the left, achievement of MRD negativity at 10 to the minus 5 level of sensitivity was achieved in 50% of the patients after 18 weeks of induction therapy, compared to 35.6% for those that received the triplet. And not surprisingly, when you look at very good partial response rates or better, the quadruplet outperformed the triplet. And at the EHA meeting just a couple of weeks ago, with longer follow-up and evaluation of MRD negativity after recovery from transplant, the rates of MRD negativity increased in both arms of the study, not surprisingly, but continued to favor the quadruplet arm at 72% versus 56% for those that received the triplet. Now, the Skylark trial is a study that Dr. Raje is familiar with. This is out of Boston. This is a single-arm phase 2 study that's looking at isatuximab with carfilzomib, lenalidomide, and dexamethasone for newly diagnosed myeloma patients. This was a study of 50 patients, and they looked at response rates, after 4 cycles of induction therapy and after induction and consolidation. And what you can see here is that the overall response rate was 90%. And by completion of consolidation therapy, close to 60% of patients had achieved a complete response. And the 2-year progression-free survival was a remarkable 91.3%, and overall survival close to 96%. So the Ischia trial is a randomized phase 3 trial looking at the addition of isatuximab to the KRD backbone in patients with newly diagnosed myeloma who are eligible for transplant. So the control arm received 4 cycles of induction KRD, transplant, 4 cycles of post-transplant KRD consolidation, and then 12 cycles of KRD consolidation / continuation therapy. The experimental arm received very much the same, but had isatuximab incorporated into the induction, the post-transplant consolidation, and the 12 cycles of light consolidation. And as you can see here on the right-hand side of the slide, MRD negative rates were better with the quadruplet versus the triplet. And I want to point out the 77% MRD negative rate after consolidation therapy in the quadruplet arm. That's at 10 to the minus 5 level of sensitivity, but the rates of MRD negativity at 10 to the minus 6 were actually close to 65% of the patients in the study, which is really quite remarkable and quite brisk. All right, so case 1, a 60-year-old patient with newly diagnosed multiple myeloma. So this is a African-American male who is presented with thoracic compression fracture, noted to have an IgG kappa M protein of 4.2 grams per deciliter and anemia. Bone marrow reveals 60% plasmacytosis with hyperdiploid cytogenetics. There are no other cytogenetic abnormalities, and the patient undergoes a T6 kyphoplasty. So as Dr. Orlowski showed us earlier, this is a standard risk patient. They're young. We're not given any information about comorbidities, so presumably this is a transplant-eligible patient with newly diagnosed multiple myeloma. So the polling question is, which one of the following treatment approaches is a reasonable strategy for a 60-year-old patient with standard risk newly diagnosed myeloma who's eligible for transplantation? A, VRD alone, B, VRD followed by transplant, C, Dara-VRD followed by transplant, D, isatuximab VRD followed by transplant, E, Dara-VTD followed by transplant. So it looks like the majority of folks have chosen one of three different quadruplet strategies followed by transplant. Dr. Orlowski, do you want to comment on the answers?
Thank you. I think quadruplet followed by transplant is definitely very reasonable. I would probably not have voted yet for the ESA VRD because the data that we have there are for transplant ineligible patients at this time. And I think Dara VTD is very reasonable as well if you're in Europe, but we all suspect that the Dara VRD would work better than Dara VTD. So I think answer C is probably the most appropriate on this side of the pond.
Yeah, I would agree with that. And I think, Dara-VTD, certainly the neuropathy with the combination of bortezomib and thalidomide and the constipation, et cetera, oftentimes makes that particular backbone a little harder to handle. So just to summarize here, depth of response as measured by measurable residual disease is one of the most important prognostic factors in newly diagnosed myeloma. Both triplet and quadruplet combinations have shown efficacy in patients with newly diagnosed myeloma who are fit. And the CD38 antibodies, when combined with an immunomodulatory drug, a proteasome inhibitor, and dexamethasone, have showed improved outcomes in transplant-eligible newly diagnosed myeloma. And lastly, treatment needs to be individualized for diverse patients with newly diagnosed multiple myeloma. And with that, I'm going to hand off to my colleague.
I'll say I agreed with everything that Dr. Voorhees presented, except for when he characterized mid-60s as being older. So that gives you some idea about where I stand as opposed to where he stands in the age bracket. But thank you for a great presentation, and I'm going to go through treatment options for non-frail patients with high-risk molecular features. And I think one of the really interesting studies in this space was the so-called MASTER trial, where you can see that patients with newly diagnosed disease, good performance status, and creatinine clearance, and without cardiopulmonary disease or other malignancies got induction with Dara KRD for 4 cycles. Then they got stem cell transplant. There were MRD assessments that were performed at 10 to the minus fifth. And then patients could go on to get Dara KRD consolidation for additional cycles, followed by lenalidomide maintenance. And one of the interesting definitions here was the so-called MRD sure group. And these were people who had MRD assessed after the indicated time points, and patients with a second confirmed MRD negative status were able to enter a treatment-free observation period with additional MRD assessments done during and also after the study. At 36-month progression-free survival among all 123 participants, this was almost 90%, which is really a pretty dramatic number. Interestingly, if you had one high-risk feature, that number went from 88% to 79%, so essentially the same. But for people with 2 or more high-risk features, there was a big drop-off down to 50%. So it's pretty clear that we need to do more for those patients with at least 2 high-risk features. Among 84 participants who got to that MRD sure status, meaning that they had 2 MRD negative results, the 24-month cumulative incidence of progression from cessation of therapy was only 9% if you didn't have high risk, or 9% with 1 high risk, but 47% if you had 2 or more, which I think bears out what many of us have known for many years, which is high-risk patients have a great response. The problem is that they don't hold their response very well. And out of 61 participants that were comprising 52% of the 118 MRD evaluable participants, 73% of 84 who reached MRD sure remained free of therapy and MRD negative, which I think supports the use of MRD in part as a treatment decision point. There also was the Manhattan trial. There's a brief overview of the design in the upper left, where 41 patients were treated with DKRD weekly, and MRD negativity was assessed in the bone marrow at 10 to the minus fifth, and 71% of these patients achieved MRD negativity with a median time of 6 cycles. That actually may be a little bit more than is our general standard of care. Many people will do 4 cycles and then move on. Maybe we need to do more. Secondary endpoints included overall response and VGPR or CR rates, and these were really outstanding at 100% ORR and 95% VGPR or CR. There was a time when we couldn't achieve 100% partial response or better. So now that we're able to do that and almost everybody achieves CR is really exciting. And at 11 months of follow-up, the 1-year PFS and OS rates were 98% and 100%, which I think is really gratifying. You can't get too much better than 98 to 100%. Another interesting study in this space was the IFM 2018-04 study, where again, DKRD induction and consolidation was used with tandem transplantation. You can see the flow, which included an initial evaluation. 50 patients with untreated high-risk myeloma were included. 36 of these patients, or 72%, did both stem cell transplants. As you would imagine, the responses deepened over time, with an overall response rate before maintenance of 100% and 81% achieving CR. And among evaluable patients, prior to maintenance, almost all of them were MRD negative, and this was now by NGS. So this is 10 to the minus sixth as opposed to 10 to the minus fifth. And after a median follow-up of 32 months, the 24-month PFS was 87%, and the 24-month overall survival rate was 94%. So certainly a very intensive therapy, but definitely one that gives very attractive outcome results. So here's a polling question. Which one of the following trials that we just reviewed reported deepened responses with DKRD induction and consolidation, followed by tandem or double transplantation in newly diagnosed multiple myeloma? And your options are A, the MASTER study, B, the Manhattan trial, C is the IFM 2018-04, D is the Griffin study that you heard about from Dr. Voorhees in the previous segment. And since he was the leader of that study, there was nobody better to tell you about that than he. And then choice E was the Cassiopeia study, which you also heard about from Dr. Voorhees. Dr. Raje, maybe you could walk us through which of these is the best answer to this question?
Sure. So this is, have I been keeping awake through this presentation, Bob, is the question. I think the trial design, which is the IFM 2018-04, was the trial which actually included the tandem transplants. So the question here was plus double transplant, which would be the tandem transplant. Master had one transplant. Manhattan, I think a lot of these patients were transplant deferred, and Cassiopeia and Griffin had one single transplant. So for that reason, I think the correct option here would be C. And in high-risk disease, I think that's the one place where tandem transplant has shown to be of benefit.
And by the way, for the record, I had no doubt about the fact that you were awake and you know your stuff so well that even if you had been asleep, you would know the answer to this question. Moving forward, I think another study that was interesting in this space was this German so-called concept trial. Now we're getting into some of the isatuximab data. This was ISA with KRD in transplant-eligible patients with high-risk disease. And you can see there were 125 patients who were in two different arms. This was not a randomization. This was based on the age of the patients. So you can see the top group were patients who were 70 or younger, not older, and they got ISA-KR for 6 cycles, followed by transplant, then ISA-KRD, and then ISA-KR. And for those patients that were not felt to be eligible for transplant and over 70, they got VRD induction, no transplant, ISA-KRD consolidation, and then ISA-KR as a maintenance. Here are some of the response rate and MRD negativity data. On the top, you can see for the transplant-eligible patients, or Arm A, with about 100 patients, as you would expect, you got deeper and deeper responses the further into treatment that you got, and 73% of patients by the end of consolidation were in a complete response. Then on the right side, you see what happened to the ineligible for transplant patients, where the complete response rate isn't quite as good, but still pretty robust at 58%. And on the bottom left is the MRD negative rate, which was 2/3 of patients with the transplant eligible group who got transplant, and about half of people in the ineligible group who did not get transplantation. Over on the right, you can see the progression-free survival rates after 1, 2, and 3 years. So 86, 78, and about 70% PFS rates for TE, or transplant-eligible patients. And as you would expect, the numbers were a little bit lower for the transplant-ineligible patients. And the 1 and 2 year overall survival rates were quite good as well. So here is case 2, which is that of a 56-year-old female who originally presented with increasing fatigue and is found to have a macrocytic anemia, but her physician decides to look further and finds an IgA lambda monoclonal protein of 3.8 grams, and a bone marrow shows 40% involvement with both a 414 translocation and a gain of chromosome 1q, which would definitely put her into the high-risk group, and she does not have evidence of bony disease, but nonetheless is a high-risk patient, and based both on her youth as well as apparent lack of other comorbid factors, would definitely be considered to be transplant eligible. So which of these would be your induction regimen? Again, for initial treatment of a 56-year-old lady with high-risk disease who is transplant eligible. And your options are either DARA-KRD alone with no transplant, or option B is DARA-KRD with double stem cell transplant using autologous cells. Option 3 is ESA-KRD alone. Option 4 or D is ESA-KRD with stem cell transplant. And then option E is ESA with a VRD. Most people voting either for DARA-KRD and double transplant or ESA-KRD with one transplant. So, Dr. Voorhees, I'll punt this over to you. Maybe you can walk us through what you would do in this setting. And of course, it's possible to have more than one answer here because we don't really have randomized phase 3 data specifically looking at just high-risk patients to guide us here.
Yeah, no, I would agree with that. And I think that the two most popular choices are both correct answers in this particular case. I think what the question is getting at is that this particular patient, if I remember correctly, has ultra high risk disease with two high risk cytogenetic features. And we actually had done a retrospective analysis of patients treated on Master and Griffin and looked at those with 0, 1, or 2 or more high risk cytogenetic features. And what we found is that those that had 0 or 1 high risk feature did equally well from a progression-free survival perspective, but those that had 2 or more high-risk features actually did the worst, not surprisingly, which suggests, that the quadruplets followed by a single transplant, whether you drop treatment because of MRD sure or not, that those patients aren't doing well with that particular platform. The IFM data from their phase 2 study with that tandem transplant is really quite remarkable. I've never seen anything like that in that high-risk patient population. So I think that's probably the best answer here. I would argue that a clinical trial, possibly incorporating a bispecific or CAR T-cell based, consolidation of some kind, would be the best choice for this particular patient.
Definitely a good answer. Dr. Raje, I'll also ask you because, of course, we do have approval for a number of VRD DARA combinations in newly diagnosed patients, but not for DARA-KRD. Is your preference for high-risk patients to use V or K in that setting?
So, as Pete pointed out, Bob, the younger, fitter patient with specifically this particular patient with 2 high-risk features, we tend to use carfilzomib. We've done the Skylark trial, which was highlighted earlier, and ESA-KRD is extremely well tolerated. Certainly would recommend an autologous stem cell transplant. Whether or not a double transplant is absolutely essential is something we can debate a little bit about, because what we tend to do in the United States in somebody like this, I think what the Master study taught us is you cannot in these patients use MRD sure to stop treatment, and patients with such ultra high risk disease, post the transplant, we would use double kind of maintenance. We would use lenalidomide with the proteasome inhibitor. And that's where I think the question of do we need that double transplant is still, in my mind, an open question. And so certainly ESA-KRD with transplant followed by dual maintenance with a PI and an IMiD would be something I would consider.
The Midas trial that the IFM is conducting will actually look at this question. So they're taking patients with newly diagnosed myeloma and treating them with ESA-KRD induction therapy. And for those that remain MRD positive after completion of that induction, they're either assigned to continued treatment as prescribed, which is a single transplant followed by maintenance, or escalation of their therapy to tandem transplant followed by maintenance. And that arm of that particular trial will help answer the question of the value of the tandem transplant. But I agree, it is definitely up for debate at this time.
Very good discussion, and I think the summary is shown here, which is that quadruplet regimens have shown great efficacy in high-risk disease, although the ultra-high risk, as you've seen, are people that we still need to do more for, and MRD negativity is a key response assessment tool.
Thank you for joining us in this episode of Integrating Quadruplet Regimens in Newly Diagnosed Multiple Myeloma. Please return to the landing page to access the third episode of this podcast series.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.